Hey guys, welcome to Pharmacology. This is chapter 11th of our 11th edition AAOS text for the EMT. Also hope that we will be able to get the opportunity to send this out to those of you that have been attending our information sessions for the EMT course. That way you can get an idea if this virtual learning is actually something that you find beneficial. Now, this being asynchronous, it'll be a tape, it'll be uploaded on our page, or I'll send you the direct link. But keep in mind, we also do the face-to-face contact. So just different options that are out there. But do want to mention that today is National Salmon Day. Wasn't quite sure if that meant go out and eat a big fish or simply wear something pretty. So I'm getting the most out of my Salmon Day, which is Wednesday, April the 8th. Then who cares what year it is? You're all still locked up at home. So we're going to start a presentation on pharmacology, give some explanations of some of the things you're likely to see as an EMT. Now, medications are important interventions, obviously. There's an example such as anaphylaxis, where we have to administer epinephrine. There can be any number of medications which your medical director has approved you to use. We're just going to look through some of the ideas about what is a medication, what is an action or a contraindication, why and the why nots when we actually use that. So we understand that also if you were able to give a medication and it wasn't for those right circumstances, that could lead to serious injury or even death. So that's why it's so important to understand what it is we're doing when we give those potential medications. Now, you certainly have the opportunity to administer medications. There's self-administered medications, whether this is a SVN, which is a small volume nebulizer, or a handheld inhaler that someone may be using. Again, so difference between administering and then self-administering, what we refer to as patient assist, two different things. Think of it this way. You carry, just go to my handy dandy drug box, something like aspirin. Now, aspirin would be a medication that you administer. If someone had a epinephrine injector and you were assisting them with that, right, there's a patient-assisted medication. So those are the two different things that we're going to be looking at. The science of drugs for pharmacology, understanding that medication, prevent or treat a disease. We also have the opportunity to potentially relieve pain. Could be ibuprofen, could be acetaminophen, it could even be Excedrin. Vivarin, I happen to have that here too. So again, there's a lot of, quote, drugs that are out there, but I think it's important we look at the difference between over-the-counter. Is this a prescription? Is it an herbal remedy? Those things all come up a little bit later. Also understand the pharmacodynamics, again, how the medication is going to work on the body. That's where we start to get into those receptors. Is it an agonist or an antagonist? And hey, great time to be looking at terminology. So an agonist actually causes stimulation of a receptor. And your example here is an opioid. Opioids are unfortunately all too common right now. I think everyone's heard of, if you look down at the next part there, the antagonist. This binds to receptor and blocks other medications or chemicals from entering that. So let's look at an agonist and an antagonist. So not the best visual effects today, but bear with me. I think you'll get this. Here's my brain. Okay, I know it's really my hand, but I want you to think of this as a brain. And someone takes an opioid. For this case, we'll use this box as an opioid. And what's happening is this is heroin, fentanyl, there's so many that are out there. It actually gets into those receptors, right? That's stimulating those receptors, and it may be telling them, hey, we can stop breathing. We can slow that breathing rate down. And eventually, if that does not stop, the person's going to die. So now we bring in our antagonist. Our antagonist is going to be Naloxone or Narcan. And so originally, we had that opioid sitting on those receptors. Now with the introduction of Narcan, think of it as creating this bind between the receptor and the opioid itself. Now it's not going to be able to get in there and actually target those receptors. So things to keep in mind about Narcan. Narcan is something that's been around for a long time. Since this nasal spray has come about, there's certainly, and this is in the protocol under American Heart Association and any first aid course, you can push this as a, quote, lay responder. From the paramedic or the EMT side of it, you may have an intramuscular injection for the Narcan. It could be the nasal spray. There's IV routes, which your ALS side is more likely to use, but that's just the initial breakdown between an agonist and an antagonist. When we look at a dose, the amount of the medication that's given based on weight, age, and desired action. So first thing you think about when you think of a dose, it could be something simple, right? You look at the acetaminophen bottle, and it says 500 milligrams of acetaminophen, take 2 tablets every 6 hours as needed. Okay, there's an example of a dose. But all different medications have dosages attached to them. It could be something like the glucose, where we say give 1 tube. How are you going to give that? We'll look at the different routes of administration. Even something like an epinephrine injector has a dose attached to that. The action, therapeutic effect that a medication is expected to have on the body, right? Not everyone's body is going to react the same way, but these are the general, this is what we expect to see when you take this medication. Indications and contraindications, think of these as the whys versus the why nots, right? An indication is a reason you give it. So if someone has a headache, hey, maybe they're going to take one of these. A contraindication, when a medication would either harm the patient, or this is important as well, have no therapeutic effect. Okay, so why do I want to take oral glucose if I'm conscious, alert, and oriented? Well, I don't, right? It's contraindicated on someone who has a GCS of 15. There's another contraindication of glucose, and that's never, never, never put something in someone's mouth. They're not actually able to protect that airway, right? If you put this in someone's mouth, they're more likely to aspirate that, gets into their lungs, and we have pneumonia. So again, indications are the whys. Contraindications would be the why nots. Under side effects, any action of medication other than the desired effect. Now, there are a lot of potential side effects out there. I think you can read any of these bottles and it says if this, that, or the other happens, go see your doctor. But that's an example of a side effect. Because again, we don't know exactly how that medication is going to respond based on different medications a person may take or their overall health and well-being. So generic versus trade. And actually what I have here, you notice the examples: acetaminophen, acetaminophen, ibuprofen. But when you look down at the trade names, Tylenol, Motrin, maybe it's an Advil, right? So all these medications generally are going to contain the same thing. Acetaminophen is acetaminophen. Just because I put the name Tylenol on top of that doesn't really change what the active ingredient is. Think of a trade name, and one of the things that we were asked to do in one of our classes was simply go to a pharmacy. Don't know how much you can do that now, but look at the difference between the Walgreens brand and then you look at the ones with the trade name versus a generic, right? This is where you start to figure out all things are pretty much the same if you know what the active ingredients are. Same thing goes with the Drano. Drano has this chemical. You look up the generic one or say a Target brand. If those two active ingredients are the same, what really makes that difference? Advertising and the money spent on that to get you to buy Drano versus some generic brand. There are some medications such as Synthroid where those off brands or generics aren't necessarily the same. But again, that's just something for you and your doctor to decide if you do have something like that you're taking. So medication names, prescription. So prescription's pretty easy. Here's my script. Pharmacist gives me my medication, right? But that comes specifically from a physician. They're also over-the-counter medications. In this lovely time of year, if you're dealing with allergies, you may have to buy the Advil cold and sinus, something that is required to come over the counter, but you still have to sign your life away and promise you're not going to make meth. Okay, but that's an over-the-counter medication. Recreational drugs, there's any number of these things that are out there. The herbal remedies, enhancement drugs, something for erectile dysfunction. Why do we even care if someone's on an enhancement type of drug? Well, these can all have interactions based on something else that they may be taking. Vitamins, supplements, creatine. How is this going to react with that? There are really long sheets every time you get a prescription, even in your regular medication bottles, that nobody reads these things. It's unfortunate. But if you do, you will often find out that oftentimes this can interact with that, create some type of synergistic or negative effect on that medication. But it's up to you to know the ins and outs of that. And that's what the pharmacist is there for as well. But when we put this together, why do I care about my patient's medications? I need to know what they're taking. It also gives you an understanding of some of the history just by looking at their medications. If you are handed a list of medications and the patient tells you this, they're on aspirin, hydrochlorothiazide, they take, throw another medication in there, right? But that can start to build a history for you. It's not a complete or a detailed one, but it gives you an idea just based on the medications that they have. The routes of administration, absorption, again, how that medication is going to get into someone's body and eventually their bloodstream. The enteral medications versus the parenteral medications, how are they going to enter? So when you look at the enteral medications, these are the ones that have to go through the digestive system. The parenteral medications, some other means. This could be an IV, it could be an IM, but again, it's a different way that medication's actually going to enter the body. So when we put all these together, let's look at these and figure out, why are these so fast and why are these so slow? And I'll give you some examples of each of these medications and really why it's so imperative that it can work quickly, immediate in some cases when we get down to, well, let's use this one, inhalation. So inhalation is something that's going to be absorbed into your lungs, going to start to fuse into your system quickly. But what are the medications that we can give in this route? Typically albuterol or Atrovent. Why are we giving those? Well, because the person can't breathe. So if they're having a hard time breathing, don't we think we should have a rapid effect on that to enter the body, right? So these are the routes. Sublingual, under the tongue. It's a rapid absorption. You have a lot of capillaries and good blood supply. That's why it's going to enter that almost immediately. Per rectum, damn near killed them, but that also has a rapid absorption rate. There's really only one medication I can think of that's going to be given in that route, and that's diazepam or Valium. That is for the ALS side of it, but it is a route of administration. You need to know, hey, we're going to give this patient something PR. Probably best to prepare yourself. When you look at the PO, per oral or by mouth, that is a slow absorption rate. That means I'm going to take my ibuprofen and, maybe in 30 minutes, you may start to feel better. So on the intravenous route, right, it's immediate. It should make sense why that is immediate. IV means it's going into your vein. That's directly into the bloodstream. The intraosseous or IO, that is another immediate absorption. Again, the IO and the easy IO drill, I think I actually have one over there. Don't really want to practice that one today, but just know those are also immediate routes of absorption. We can get into the intranasal. Intranasal is another one where we've seen a huge influx or increase in Narcan being administered by that route. It really doesn't have contraindications to it. Anyone that's not breathing or slow, shallow breathing, you have suspicions that they may have overdosed. You have the Narcan, yeah, you push it, but we also see a rapid absorption from that. Intramuscular, what's going to be used intramuscular in your world, that is most likely going to be the epinephrine auto-injector. Again, just press this against the leg, it shoots out. It's a pretty good response rate on that as far as 30 to 60 seconds before we start seeing the effects of the epinephrine. The subcutaneous don't really, I mean, there are medications that can be given subcutaneously. One of those happens to be epinephrine, and epinephrine can be given that subcutaneous route, but not a lot I see at the EMT side. Think of your TB skin test. Did you see TB skin test? That was subcutaneous. Transcutaneous is going to be slow. Again, your more common routes for this, think of the inhalation route, potentially your intramuscular route as well. So the different forms that medications take will dictate the route of administration. Tablets, capsules, how do you think we're going to take those? Yeah, we're most likely just to swallow them. There's solutions, MDIs or meter dose inhalers. Again, obviously that's something they're going to have to inhale. The gels rubbing on the skin, gases for inhalation. Hey, oxygen is your friend. So again, understand it has a rapid absorption rate. Tablets and capsules, some type of gelatin shell filled with powdered or liquid medication. Again, if you get bored, you can go look through your medicine cabinet. Tylenol used to have one of these that was a gel coated. You open it up and all these little balls would fall out. That was just kind of neat to see. Tablets, other medications, or I should say materials, will mix to actually keep that stuff together and actually compressed until it gets into your system and starts breaking down. And that's why those tend to have slower absorption rates. The solution, we've got the mixture, cannot be separated by filtering or letting it stand. Okay, so it's not going to come apart. The solutions can also be given as IV, so intravenous, intramuscularly, or a subcutaneous injection. Now, the suspension, a little bit different. It does not dissolve well in liquids. It separates if it actually stands or is filtered, but and I may be wrong on this, but I can't think of any medication route currently for EMT that may be using a suspension. Meter dose inhaler. So if you have a history of asthma, and there are a lot of people that do, or they have a family member, you have most likely seen one of these. What it does is it spends, as you depress that, it spits out this fine mist. People that use inhalers generally know they need to exhale, breathe that in. But what's important about an MDI, and it's in the name, metered dose, it delivers the same amount of medication each time, right? They take a puff, they may wait a couple of seconds, they take another puff, but typically 2 puffs are what equal a dose, and that may be anywhere from 5, 10 to 15 minutes apart. Typically, I've seen the 5 minutes apart, but read the box, know how you're actually going to administer or assist with that. On the topical medications, ointments and creams, the lotions, think of a calamine, hydrocortisone cream, right? Something that you rub into the skin, it actually gets in and may start feeling better. Calamine, when I think about calamine lotion, I want to say poison ivy or poison oak. Neosporin, you have a cut, yeah, you just put a little bit on there. Not carried, not carried, not carried on EMS. But why is this important? Because it is a topical medication. You need to know what someone is taking. Transcutaneous medications are absorbed through the skin. These can be any type of medication. It could be a nitro patch. I've seen these in fentanyl patch. I've seen these in hormones. So again, say we're going through and doing an assessment on someone, thinking about medication right now, we're more concerned with airway, breathing, circulation, those life threats. But let's say you expose someone's chest and you happen to see these 9 or 10 stickers. So it's always with a gloved hand how you want to take those off. What I was alluding to in this case was fentanyl. Fentanyl is something that can be as a transcutaneous medication. Different gels. And I happen to have the gel or a gel here, which is glucose. So even though it's already contraindicated for me, because I'm conscious, alert, and oriented, and I'm not suffering from hypo or low blood sugar, just want you to see, well, number one, what flavor this is, but how this can be such a concern if we were to put this in someone's mouth and they actually weren't able to protect their airway. So Well, wasn't expecting that, but let's see. Now, it's gonna go to a little cold in here. Just imagine someone taking that in. Don't really taste bad. It's just sugar. But taking that in, that viscous solution, calls it a semi-liquid. I don't know if it's good to wash sugar down with non-sugar, but just think about putting that in someone's mouth. Let me use my handy dandy facial mask. Wipe that off. But that's the concern, right? That is a gel that goes into someone's airway. They suck it in. It's certainly going to be contraindicated to give them that if they can't protect their own airway. Gases for inhalation, oxygen, it's most commonly used gas, usually derived through a non-rebreather mask, nasal cannula. Again, we've got multiple ways to administer oxygen. Think about the differences in your concentrations, whether that's room air, which is going to come in at right around 21%, or all the way up to the bag valve mask, which is capable of getting you close to 100%. The 6 rights, if you are old school, you remember these as the 5 rights, but we need to make that modification, the documentation. Documentation is something that was never actually thought of as a right before, but it is important because from chapter 1, you should remember, if you never wrote it down, then it obviously didn't happen. So document, document, document. The medications themselves can also be, witnessed a lot of time on someone's actual prescription, right? Do I have the right patient? Do I have the right medication? Is this the right dose, the route right, the route time? And then of course, that you have to write this stuff down. So you should always think of these again as the 6 rights, all the way down from your patient to the documentation of what you're doing. The medication administration in the EMT, so circumstances to administer medications. Peer assisted, and I actually have a peer assisted medication that I have not seen for a while, but it's the atropine and the 2-PAM chloride is simply an auto injector. But these are peer assisted medications, right? Here's my partner. Hey, I can't give this because I'm too ill at this point. So maybe they can inject me. Maybe they have to inject themselves. But that's a peer assisted. Patient assisted medications, and that could be you're assisting someone with their inhaler. We think of the EMT administered medication. Let's go back to whatever it is that you carry, such as aspirin. Then you're actually administering that. When you look at what and who make those decisions, the state and local protocols, of course, with your medical director, the AZDHS website has a plethora of resources to see what medications can actually be given. Some are STRs or special training required. But again, this is all going to be based importantly on your agency as well as the medical director for that agency and whether or not they think it's appropriate that you administer those medications. Activated charcoal. The charcoal is an adsorbent. Okay, an adsorbent means it's going to get into someone's stomach and actually suck up that toxin that was in there. Charcoal obviously is contraindicated, or we don't give it to patients who have an altered level of consciousness. They could, potentially gag or aspirate on that, just like you could your glucose. But carrying charcoal versus non, this seems to be in at some times and out at others. I would just say refer to your current standards or whether or not you're going to give charcoal. This is a tablet form of the charcoal. The charcoal that I have seen has only been in liquid form. It generally comes with a sorbitol or something that's going to, help not bind up the person, if you will, because one of the major side effects of charcoal is constipation. Cheap price to pay, if you will, but sorbitol can help relieve some of that. Now, oral glucose, again, we already know what oral glucose is. That's the sugar, that is life, that is your energy. It's used for hypoglycemia. And what is hypoglycemia? When you look at the standard range for a patient's BSFS, there's a term, blood sugar finger stick, you should expect somewhere between 80 and 120. But we do this all the time in class. And someone will check their blood sugar. Hey, we check our blood sugar. So we got 20 people. And guess what? Not everybody falls between 80 and 120. Again, there's some normal variances to this. The person that didn't eat, and this is an 11 o'clock class, maybe they're sitting down here at the 60 range. Maybe they even fall into the 55, 50 range. But if they're not having problems concentrating, their level of consciousness is good, right? Do I really need to give that person that oral glucose? So treat the patient, not a number, right? All blood glucose is, it's a number. But if they have the mental status and they're answering questions appropriately, maybe we obviously don't need to give them that. Should they get something to eat? Probably, but we don't need to load them up with oral glucose. Don't give it to an unconscious patient. I think we've driven that point home. The aspirin. Aspirin is a fantastic drug. Aspirin inhibits platelet aggregation. So what aspirin does, it actually blocks the production of something called thromboxane A. Thromboxane A is defined as a potent platelet aggregator. And that just means you're going to keep all these things tightly sticking together. And as you give aspirin, it allows those platelets, instead of, think of these as being in groups of 5 or 10, maybe they can now go off in pairs of 2. Maybe this one has a single one, but it's that inhibiting the platelet aggregation that we're looking for, which creates this easier passageway of blood for someone that could potentially be experiencing a heart attack or what we call chest pain. We want to be careful giving it to those that have a known history or sensitivity to aspirin. There's liver damage, there's Ray's syndrome. This is kind of funny. We should not give it to children. If you look on the back of your aspirin, this is, hey, children's aspirin, 81 milligram tab. Again, pre-hospital, we should not be giving aspirin to children unless you, of course, have specific orders for doing that. Sublingual medications, the most common one is nitroglycerin. Nitroglycerin is something that's going to hopefully relieve this angina or chest pain. It is a vasodilator. So with a vasodilator, when we increase the size of someone's blood vessels, we may see this drop in blood pressure. When you combine that, using this with medications such as a Viagra, you can have an unhealthy combination. It also, again, it is a tablet, nitro 0.4 milligram tab delivered sublingually. There are meter dose sprays. I fortunately do not have any of the sprays there, but again, that would be considered a meter dose just because it should put out that same amount of medication each time it's administered. Intramuscular injections, yes, epinephrine, also called adrenaline. What are the side effects of epinephrine? Well, to determine a side effect, we should probably think about what the medication does. It's a bronchodilator, it's a vasoconstrictor. So the vasoconstrictor effects are going to increase that patient's pulse. It may even cause them to be, jittery, the uncomfortableness that they have in their chest. Again, but why did we give this, right? Epinephrine in this case is only going to be given for anaphylaxis. So if they can't breathe, we need to open up the airway. Now, just a little critical thought. I have someone who was stung by bees. They are allergic. Now, they're obviously having a hard time breathing, but what about that person who also is experiencing chest pain? Well, if you don't have an airway, you don't have anything. And so always maintaining the patency of that airway or trying to get them breathing as easy as they can on their own. Can you still treat the chest pain? Can you transport? Absolutely. So let's make sure we address that airway issue first. Naloxone, again, this is the nasal spray or the cone. It is used to reverse the opioid effects of an overdose, but it also has a short life to it. Again, you may push that Narcan, 2 minutes later, the person's fine, but then 4 minutes after that, they're back to that same hardly breathing, and you may need to give more. So anytime, even if this is utilized in a non-professional or non-EMS setting, always call 911 if you're going to be using Narcan or have that suspicion of it. Meter dose inhaler, I actually skipped a slide on that, but this was actually getting to the inhalation medications where we actually nebulize something. I will work to nebulize a couple of different things later on, either today or tomorrow, include this on here. But the key premise of this is we're going to take something that's in a liquid form and we're going to turn it into a gas. When you do that, now they can inhale that medication and it's going to get delivered directly down into the alveoli. So it's a fast absorption. It's an easy route to access. This thing is portable. You obviously need an oxygen tank at 6 liters a minute to come up and turn that into a mist, but that may be easier as something you can actually see. Patient medications, the assessment includes finding out medications. Well, yeah, we need to know what medications they're on. I told you a little bit about this, about finding out about a patient's condition. Maybe they're unconscious, unresponsive, and they can't tell you anything, but all you know is here's a list of medications you find in their home. So we're still going to run through our own algorithms for this. Just because I see this person takes, whatever medication it is, but does that help me determine what's actually going on with them right now, right? Don't get the tunnel vision and think, hey, this is, they take or have glucose pills. Well, it's got to be a low blood sugar. You start doing your assessment, find out there's not breathing, there's no pulse. Well, okay, then we're going to go into that treatment with CPR. But obviously it's helpful for the emergency department simply because as you give those medications, is there anything else they may want to onboard to that patient that has these potential interactions with that? Medication errors happen, but what's bad is when you don't own your error, okay? If I gave a patient glucose and they were conscious or warranted and their blood sugar was 90, giving someone a tube of glucose isn't going to kill them. But if I give them something, that I shouldn't, which has the potential to really decrease their ability to overcome whatever it is that they're experiencing, we need to document, take care of that patient, but notify your medical control, be honest with it. Okay, you have to be honest with any mistake that you made. Mistakes happen, right? It's going to happen. But it's your honesty which is going to go a long way in how this is dealt with. And of course, obviously working to find some type of antidote for the patient if there is such a thing available. So this is a quick overview of pharmacology and with the medications. The nebulizer, I will put that on my list to get you something in the next couple of days just so we can see that process. But I hope everyone enjoys the rest of their salmon day, and I will see you all again soon. Thanks.